awareness around kidneys, symptoms, what kidneys, how they function, knowing your numbers, your infiltration rate, all of those things. And I think that we've got a lot of work to be able to do to improve that. But what you don't want is to do it without having access necessarily available. Because if we go out and screen for these patients, we need to have an intervention that's ready waiting for them. Otherwise, ethically, you've got to ask yourself why you're looking for them.
Yeah.
So I think it's a parallel process that needs to happen. We need to drive access, and at the same time as doing that, we obviously need to do everything we can to improve our understanding and awareness, and obviously our interventions early on.
Yes. Dr. Shiva, as she was talking, I saw your hand wanting, when you're in a class and you want the teacher or the principal to know that you have a question. So please, your question or comment that you had as she was talking. You talked about the eGFR, estimated glomerular filtration rate, in the context of knowing your numbers. With BP, with cholesterol, with blood sugar, with BMI, people now know their numbers. The campaign has always been know your numbers.
Your vitality age.
Yes, but the number for eGFR, the 89, not many people know about it, that ideally your glomerular filtration rate should be 90 or above. So just talk about that in terms of how we can break it down to an easy way of understanding for somebody who didn't go to medical school.
Sure. Maybe let's just continue on the aspect that you're saying that we aren't well educated enough. So I will say that the National Kidney Foundation, in collaboration with us at the Ellen Joseph Hospital, which is a state sector hospital under the University of Witwatersrand, we have done these videos of primary kidney awareness, which is available on social media platforms. And you may ask why social media platforms if we're looking at a state sector, but that really is targeting the patients that are most vulnerable, young males that die of kidney disease. We've looked at such social media platforms that are utilized by them, and Facebook, TikTok, Instagram, yes, YouTube is what I was thinking of, is utilized by this population because smartphones are actually easily available. So this provides videos of general questions, simple things that can be done, preventative measures, explaining kidney disease in a very simple manner. And on this platform, we also explain this concept of estimated GFR that you may discover on a blood test that was incidentally done for some other reason. We know that there are 5 stages of kidney disease, and we know that we use this in conjunction with a urine albumin to creatinine ratio. So earlier on I alluded to a dipsticks, which is actually cheaper and more readily available, but if we're looking for better accuracy, we do send the urine to the lab and look at the albumin creatinine ratio. So let's go back to the GFR, and basically in its 5 stages, you said the number 89, but to make it easier, CKD stage 1 would be a GFR above 90, and 2 between 60 and 90. So once you reach stage 3, if you see a value of 59 and below, I suggest that that is sort of the red flag to refer your patient to a nephrologist. And if it's below 15, you know that that is stage 5, which we call 1.5, end-stage kidney disease. So let's not confuse the audience with the actual values, but just big numbers to remember is if it's below 60, we know that this is stage 3, maybe 4 and 5, and as you can delineate from what I'm saying, the greater the number, the more severe the disease. When it's less than 15, we're now discussing end-stage kidney disease with or without dialysis. So if the number is below 60, please refer your patient. Then when we look at albumin in terms of protein in the urine, the type of protein we're looking at albumin, we also grade that A1, 2, and 3. But basically, once you're leaking more than 30 milligrams of protein per day or on-the-spot urine, that's what we're looking at. And that's how we sort of classify our patients. But the big thing for you to remember is the value below 60, even if it's above 60, and it may not be all that normal for the patient. Maybe the patient has 1 kidney. In all these conditions, the best thing to do is early referral so that they can be optimally managed. You don't necessarily need to wait for the value to be below 60, for example. They may have other reasons. They may have recurrent stones and so forth. I did, in fact, forget the second part of your question, or did I answer it already?
Well,
based
you
on
answered
the
it.
EGFR?
I was just, linking to the EGFR that we had mentioned earlier, and trying to just say, let's break it down.
Sure.
In terms of its importance. Remember, you said the dipsticks is very important, but maybe the EGFR is even better.
So let's just break it down to the blood test, which we're looking at the GFR, and E stands for estimated. Sure, we have better ways to do this where there's cystatin combined with creatinine for a GFR, but this is all cost related and what's available in your institution. Why I referred to the urine aspect in the urine dipsticks is that maybe all that's available in the public health sector. You may not get a blood test immediately, and you may notice 2+ protein. Yes. And that would warrant you to want to refer your patient to us. You may not have access, as you've mentioned, maybe in the outer skirts of South Africa.
Yes.
You may not have access to easily available blood tests and results.
Yeah.
So that's what becomes quite important.
All right.
Thank you.
I wanted to ask you somewhat as a learning as we go here. Patients, because I think in the private sector, often if you're feeling you've got a bacterial infection, you're not feeling well, you go to the, you've been to the doctor twice, maybe they'll refer for blood tests. Do those rates, are they negatively impacted by having a simultaneous infection? My reason for asking is I think a lot of the time that's probably the only time that anyone actually checks it does a kidney function, and I want to make sure that they don't then take a negative value, what it shouldn't be, and tie it back to, okay, but the patient's sick at the time they're dealing with an infection. Is it closely linked? Does it alternate?
In the face of a bacterial urinary tract infection, you could have blood in the urine, you could have a bit of protein. It may not strike up as 2+ on your dipsticks. If anyone has ever seen what a urine dipstick looks like, it's graded 1, 2, 3+.
Yeah.
And you can look at the color on the bottle, and you can easily read this. So the wise thing may be to do, if it's easy for the patient, they live close by, to come back once they're treated and review and repeat urine if needed. Sometimes these are done in patients that are hypertensive and diabetic, completely a primary sort of screening method without any symptoms, and that's what we're really driving here, primary screening.
Thank you very much. Earlier today, Campaigning for Cancer had, I'll call it, an event where people in some, I'll call it a campus, the different offices, different companies, people were given an opportunity to actually have urines tested with the dipsticks, blood sugar, blood cholesterol, blood pressure, and quite a number of people who came. They were very happy. They say it's not often that they get their urines tested, which brings the point that that simple test done at a first level of care actually can be. I mean, there were people where stuff was picked up, diabetes, where there was like sugar, 1 or 2 with protein. Luckily, there was no one with blood in the urine and stuff, and those were referred, to their treating doctors so that we can, follow up with proper pathology tests and referrals appropriately. So I'm just saying, Campaigning for Cancer are already trying to see how to bring that first level of screening. That was a campus of workplaces, but this is stuff that needs to go in the communities. Right, so back to your other head, Doc, Dr.
Starting to regret these hats.
No, but they make you whole. Yeah. So this may be a bit of a controversial question. I hope not. But as the deputy chair of SAMA is very clear about their opposition to NHI. And so as we are talking, what we are talking here, and talking about what the future might look like, the organization that you are actually representing is not necessarily, they agree with the principles around NHI, but they are not so happy with the how to get there. So can you just, in the context of bringing access to care for people with kidney challenges, with that radical system that is being brought, they said 2026, I'm not sure if it's going to happen by 2026, and there's still at least 2 years to get there. Just how are you guys seeing this thing? You know, we're opposing this future that these guys are talking about, but at the same time we need to get ready for that future, because it sounds like the political will is very strong to bring that future. So I'm just trying to because remember, primary health care, they are looking at a future where primary health care is going to be the backbone of the healthcare system, supported by the other different levels, moving away from a system that is more curative, tertiary, you know, kind of focused, but primary focused and appropriate referrals. So in the context of this big change that is being brought, and your opposition as the organization, aren't you guys a bit schizophrenic?
You say controversial. I represent, or I sit on the committee that represents GPs. It's called the GCCC. Triple P. And essentially, I think the position of SAMA is not against NHI.
Yes.
It is the same narrative for everybody else.
Yes.
We all believe that access to universal healthcare is essential. That
At a principal level.
At a principal level, it is essential. At a practical level, for our setting, it is essential because the current health system we have is not sustainable,
Yes.
right? It is not inclusive.
Yes.
Everybody gets fixated on the bill,
Yes.
which is a bill.
Yes.
It doesn't speak to rollout. It doesn't speak to implementation. And I think that's the essential message that needs to go out. Once the bill is signed, then we get into the nitty-gritties of the how. We all hope, because we want to see it work, we all hope the implementation will happen well. We don't deny the history we have of how finances have been managed in our leadership,
Yeah.
right? But we really are hoping for the best. From a doctor's point of view, from a GP point of view, there's a lot of good that comes with that migration.
Yes.
And if we bring it back to what we're talking about now, if we make sure that the diagnosis, or rather prevention of kidney disease happens at primary health care, as you said correctly, that this will be the pillar. You will not have patients bypassing the primary care and moving to tertiary too quickly and straining resources there.
Yes.
You will make sure that at primary health care level, you are actually educating first because you are closest to the community.
Yes.
Secondly, you make sure that whatever personnel forms part of the primary healthcare facility is well aware of the essential screening that has to take place. And what we've moved to is to move away from doctor-centered diagnostic methods. But we've got nurse kind of approaches, we've got community healthcare work kind of approaches, we've got what we call your ward out-based teams, which are in the community itself. All of that forms the network of primary health care,
Yeah.
which again is the pillar of where we want to move with universal access.
Yes.
So I think there's a lot of benefits. The maybe individual opinions,
Yeah.
or and those are welcomed.
Yeah.
But let us admit that it's nothing that we can run away from having as a health system.
Yeah.
And what I essentially like about it as well is that we will finally see an integration of general practitioners forming a part of a primary healthcare community, because at the moment it's in silos. They see themselves separated somewhat because there's this private health, public health. You understand? But that integration makes sure that we have a much better formulated structure that increases access actually, because you probably have more GPs in communities than clinics. especially in the kind of communities I serve which are under-resourced.
Yeah.
So yes.
Okay. So, campaigning for cancer, what role do you guys envisage playing as campaigning for cancer in actually ensuring that primary health care does, become, that space where people are screened early, where people are given the right information, so that they can then be assisted appropriately?
So I think patient advocates play an enormous part of that, because there's a trust in the community when it comes to patients and that referral. I think as patient advocates, we have a role to play both at a policy level and at a health promotion level.
Yes.
At a health promotion level, we should be making sure that our communities understand their numbers.
Yeah.
But they also understand when they're at risk for certain diseases. And it's one of the reasons why often Campaigning for Cancer will integrate other disease areas into our discussions, because of the linkages that it has with that. We work a lot with child and maternal health as well, because of the relationship with childhood cancer. And that, so there is that responsibility of us to work together as patient advocates with the communities, so that we're not confusing communities, and that we're giving them simple messaging in health promotion to understand and to know who is at risk for what.
Yeah.
But I think at a policy level, at this stage of the game, the importance becomes on understanding that primary healthcare is not just handing out paracetamol.
Yeah.
Primary healthcare is making sure that you're preventing the diseases that you can, that you're looking at you're diagnosing and referring patients for any disease as quickly as possible, so that the ultimate downriver cross and downstream costs are reduced, and that we're getting better health outcomes for patients and better quality of life. Because at the end of the day, everyone who's involved in the healthcare system, those are the two things we should be striving to. Better outcomes and better quality of life.
Yeah.
And I think, we look at two processes that are enormously important at the moment in healthcare. And that is the establishment of what that basic basket of primary health care will look like in NHI.
Yeah.
And more immediately is the PMB review of happening with the Council for Medical Schemes, which is in fact at this stage looking at primary health care and a primary health care package. That's important. That's never been spoken about at the PMB review. But it's imperative that patient and primary health care practitioners and referral doctors and tertiary doctors are included in those discussions.
Yes.
Because those voices, and those are the voices from on the ground, they understand what's going on in the ground.
Okay.
And that needs to be brought forward.
Thank you very much. I'm not sure if all of us know what a PMB is.
PMB, prescribed minimum benefit.
So in the private healthcare space, we've got the regulator of medical schemes, and these are conditions that have to be treated, and the medical aid cannot say by June, no, the benefits are exhausted. In the early 2000s, even for HIV, by June, people will be told your scheme can no longer, afford the medication, and come next year. Meaning, nobody can say your benefits are finished for ARV treatment. So, but this is for many conditions. So, the review is therefore looking at those conditions where the schemes cannot say your money is finished. But we're talking here about 16–17% of our population who happen to have medical schemes. There's 83%. Obviously, who have to go and queue in the public health sector. All right, I don't want to monopolize this. there are people here who would like to ask some questions. If there's anyone who would like to ask a question, please just indicate so that this esteemed panel can be able to just clarify or say something. Now, Ruth, on my right, she is from AstraZeneca. She does so many things. She interfaces with government about many important things, but she also interfaces with NGOs under the Pagamisa brand. And one of the things I did a few weeks ago was to interview the CEO, well, I'm not calling him CEO, the president of Africa Cluster, AstraZeneca. And he was very happy talking about the 5 therapeutic lines of drugs that they sell out there to the market. And he was very happy about the rare diseases therapeutic line. All right? So we've got somebody who represents that group of rare diseases, and you come from a company that is actually specializing in those rare diseases. Is there anything that you want to say to her?
They definitely just threw me under the bus. So we work very closely with the Rare Disease Association. So we work very closely with the Rare Disease Association and other patients advocacy groups, locally and internationally. And it's very important because we need to make sure that we work together to improve access for patients. Those are very few patients, but it doesn't mean that their disease is smaller. So we need to make sure that there is access. We also need to make sure that there are investment cases that are built to ensure that the funding is there. In my world, on the economic side, we talk about the cost of inaction. So we are doing a lot in that space to generate reports that can be used, because we believe that they are actually incurring a lot of costs now and downstream by not actually funding for those kind of medicines. So it's very important for us to work with different partners to make sure that the access is there.
Now, the fact that there are fewer people with these conditions, and therefore the likelihood that the meds would be on the expensive side. I'm assuming that the thing about volumes, more people that you're selling to, maybe the prices could be lower. Fewer people that you're selling to, the prices will be higher. But we learned during the height of HIV that actually there could be pressure put on people like pharmaceuticals to, increase access at much more reasonable pricing. But I'm not sure if you want to answer that. Maybe let's leave that. All right. Questions, guys? Yeah.
I was instructed not to ask anything, so this is a bit of a tough moment for me. Okay, as a patient coordinator, my question is for you. So you're looking at me and I thought you knew that I was going to ask you a question. My question is for you. In regards to screening, right? With some of the diseases, you mentioned that prevention would always be better than a cure. With some of these kidney diseases, you would have it as a genetic, it's a genetic disease. Like with stenosis. English. It's not Englishing. Yes, like that one. It's a genetic disease. And how would you go about in explaining to a family somewhere in the rurals that have no idea what this is? They go to their local clinic. How would a referral process would have to go about in making sure that this patient actually gets screened? Because their first instinct would obviously have to go to the nearest clinic. They get there to the nearest clinic and they get given, drink water. Some of them, drink water. Here's some pain meds, you'll be fine. Only to find out that the damage along the way is going to be worse, and it will eventually lead into this patient losing their life.
Sure, so thank you for that pertinent question.
Thank you.
I think it highlights back to this relationship that we have to have with primary healthcare, because at this point it would be crucial to identify that there would be a genetic condition. You may not be able to test for it, but if it is identified and you cannot early refer, you also need a structured team with maybe the genetic team, you need counselors, you need psychologists and so forth, and obviously the patients need to understand this in their vernacular language.
Yeah.
That would be really important. But there are ways and means to refer the patients, but just in its most affordable sense. So we do have these avenues to help patients. And we can do this in terms of group awareness and so forth, but it has to be in conjunction with the primary health care level, and this is where we need to actually strengthen our foundation and work well together. So there are ways to address this, but you're highlighting a really important deficit in this sort of communication up to the point of referral, because we lose a lot of patients to referral because of the lack of understanding or the inability to afford transportation to get to us and so forth. So there's many avenues and challenges that need to be addressed, but this is something that we have to work together toward.
Can I just come in? And I think if we also go back to simple healthcare delivery and focus on the quality of healthcare that we give at primary healthcare level to our communities, you're not likely to miss that if your history taking is maintained. Because in your history taking, you ask about family history, and at least there's an area where you might be able to pick that up just at that early phase. And I think this is what we're trying to really drive in primary healthcare with the Office of Health Standards, that the actual quality of the healthcare delivery that's happening in primary healthcare does get looked at, including having interviews with patients that access that facility as one of the criteria of accreditation, taking us back as healthcare professionals to making sure that we stick to our principles of extracting information from our patients as well.
But Doc, sometimes you've got 100 patients to see, so you've got limited time, so zooming into history may not always be like deep.
But it should not excuse our quality of health.
No, I'm fine. I was just being naughty there. Yeah, please. Yeah.
If you have a recessive disease, you may not identify it in every line of family, preceding and thereafter. So, if you may not get the best history from your patient, there are small clues. So we are talking about screening tools. Then maybe you would see some sort of acidosis in a cystinosis patient, so the bicarb. Anything that triggers concern should warrant rather cautious early referral than not. I understand that you're also mentioning that you don't want to burden the tertiary facility and so forth, but rather we err on the side of caution, especially when these patients are young and something is not sort of ticking the boxes, or the patient's not recovering and all sorts of medication are being thrown into them, and like you said, it should not just be paracetamol. So I think when we look at family, we aren't able to get the best family history because we're not sure of the mode of inheritance. Maybe let's also look at their age, let's look at their lack of response, and let's look at other factors that could be contributing, because the full urea and electrolytes are available in the primary healthcare sector. You are able to refer if you see an acidosis, for example, that's not resolving, or some sort of growth, there's stunted growth. There are many other indicators if you do not have the time, because you're able to assess this by just looking at biochemistry, looking at the patient. That doesn't take much time.
Thank you very much. If there's a question.
So my name is Dario, I'm from Aspen Pharmacare, and I want to ask a question, and I'm happy to see that there's a lot of focus around this area, because there is a huge need to create awareness in kidney disease. And we've spoken a lot about prevention and how we can focus on preventing the downstream effects of lack of awareness, whatever it is. But in terms of access, and we've spoken about access from a chronic kidney disease point of view, and access to dialysis is a challenge, right? It's a huge challenge in the country. So is this something as well, and I'm asking the panelists and whoever feels they can answer or add value, how are we going to look at, obviously from a dialysis point of view, opening that point, and then also from, and you mentioned it, end-stage renal disease and needing a transplant, right? How are we doing and what are we doing to try and create an awareness in terms of kidney transplantation or kidney donation or donation in general, right? And I think that's probably where you fit in, Kelly, right?
No, this is I wanted to say earlier, transplantation is something we haven't touched on. And it's such an imperative element, because I think there's a couple of, obviously from a referral perspective, you're wanting doctors to refer earlier. My kind of drive is, how do we educate patients to know what to ask and to drive their own screening to some extent? Because that is ultimately, if you've got an educated patient and a patient who's got a good awareness, generally you find that they get more done earlier. So with regards to transplantation, in the Black community, there's such a stigma around organ donation.
Yes.
Okay? Because from a cultural perspective, and particularly, organs that you require after you've, it's like they have to bury the body whole.
Yeah.
It's a massive thing. We sit and we're like, no, but I mean, surely they know that they don't need their organs anymore. It's a cultural belief that you cannot just change with the conversation. So we need to start, you need your ancestral healers, you need your traditional healers, you need your grandparents, etc., to understand, so that knowledge starts to filter down. Because I've never forgotten, I spoke to a gentleman who was diagnosed with a condition when he was like 23, and he was in end-stage renal failure at that point, and he needed to have a kidney transplant. And understanding the tissue matching issues that you have in the Black population because they have no donors. And the journey that he went on trying to actually, and I've never forgotten that conversation. It's been something that's always sat with me. Because I was just like, there's so many different elements to that conversation that are out of his control completely. And that's why I was asking the question around, if you've got if you're sitting with an infection or whatever, how do you know to go back? What can we do as people engaging patients more regularly, to encourage them to go back? I'm going, when I check my vitality age, why are we not checking my kidney function? Why is that not on there? Why do I not know that number? I'd like to know what the cost of, for one dialysis treatment, how many patients you could screen for the same cost. What is that number? Because I'd like to pick that up with the funders, particularly from a screening perspective. Because I feel like there is so many dialysis machines, and they are timely. You're on a dialysis machine for X amount of hours, this amount of time. It's finite. Screening is like infinite. You can do it regularly. Why are we not doing it, and what can we do to improve that?
Can I just comment on the screen?
You can comment and then, okay.
All right. I want to comment on screening, and I think what we have not migrated quickly enough to is self-screening. I'm involved right now in a study to self-test for hepatitis C, which is quite, not as well known especially in the public sector, but we're doing it in the communities of drug injectors, who are often thought to be out of it most of the time, and they're doing it. We are having, HPV screening done. You pick up a kit from Ampath, you do it in the comfort of your home. So the more we do that, a dipstick a bottle is 200 Rand at discount, 2 Rand a stick. If they must sell it in just sticks, then these are some of the things that we might need to migrate to, to empower the patient, and they don't have to wait for the clinician to suggest a screening test. And I think that should be the way we should be going.
So I'm Malcolm Davies. I'm a slightly older, slightly more tired, and definitely less glamorous version of Dr. Chiba. So if I might make a couple of comments. This is not a rare disease. There are 140 million people in the world affected by chronic kidney disease. That's twice the number of people living with diabetes. It is 20 times the number of people diagnosed with cancer. The risk factors for chronic kidney disease are very well known in the South African sector. It's diabetes and hypertension and HIV. Genetic causes are very, very rare in our setting. Although the most common genetic mutation in live births, autosomal dominant polycystic kidney disease, is a cause of chronic kidney disease. we don't see a lot of your rare diseases are very rare contributors to chronic kidney disease in the local context. And I know this because we have recently published the largest series of HIV-associated thrombotic microangiopathy ever described, so perhaps afterwards we might have a talk about what we can do with that. It's very, very simple. We don't screen. The reason we don't screen is because we don't have sufficient knowledge amongst our primary health care givers about who to screen and how to screen. So in the state sector, for example, we've also published data that shows that most patients referred to a specialist nephrology service are already in CKD stage 4 or 5 at the time of referral. That is far too late for us to be able to do anything. It's all very well to talk about vitality points. 85% of the population are not on vitality. They're dependent upon the state sector for their health care. That means they're going to go to the state care facilities where they're going to be screened. So the only way in which you can improve this is possibly through NHI, where people have better access to the sort of primary level care where we can screen and make diagnoses earlier. Because there's no doubt if we can make a diagnosis earlier and start intervention earlier, we can slow down the progression of chronic kidney disease and keep people off dialysis for longer. There was also, somebody made the comment, it was Dario, about the lack of dialysis facilities in the country. So since 1994, the state has added 2 dialysis units, whereas private has added 250. So there is a huge need. Equitability of financing of the health sector may be one way to improve access to dialysis. But also, as was stated, we actually don't want people on dialysis. The quality of life is not great for the patient. It's also not great for the family. And we've also, in our Ellen Joseph series, published on that in international literature. So we want to catch them early and stop it from progressing. Transplantation obviously is a life-changing treatment for these patients. I want to take issue with the statement that was made that black people don't like to donate. In fact, we've published the largest series of people in the African setting being worked up for transplantation from the cohort at Sharp-Maclicker. And what we show there is that on average, our black patients bring 4 family members before we find one who can possibly donate, whereas Caucasians only have to bring 1 or 2. That's nothing to do with the matching. That has to do with the fact that, as Dr. Chiba said, kidney disease is partly genetic, but it's strongly socioeconomic. And what you are looking at, the high rates of CKD that we see in the local population, is the intergenerational effect of poverty caused by our apartheid past, which we have yet to address. And one of the ways in which we may be able to address that apartheid past is by improving equitable access to health care, to nutrition, etc. That's where NHI may make a big difference.
Can I just add one thing?
To Dario's comment on transplantation. So we do know that a living donor would be better than a deceased donor. And there is this concept of paired kidney donation, if you've heard of that, where maybe 2 members here need a kidney and there are 2 donors, but then each other's the relation that is not sort of a match, but if we had to swap around, we can be matches for each other. And that's sort of, or you could start with an altruistic member of society that donates and sort of follows that pattern. So that is also a window to create more kidney, or organs rather.
Thank you.
I just want to clarify my statement with regards to the organ donation. So we obviously we cover a wide variety of organs that are required in the diseases that we cover, and in the lung transplantation space, in obviously heart as well, heart and lung. It is the black patients really do battle a lot more because of the cultural belief. And I think Nomsa could probably attest to that in terms of speaking to the patients. It's a massive, it still remains, I think living donors is easier because you've got a family relative that is needing, and it's your child or it's your sister or it's your mom, so it makes it a little bit easier. But in organs that are
harvested.
Harvested organs, it makes it a lot more difficult.
Do you want to say something?
Okay. Let's
Yes, I'll get it.
yeah.
So I mean, the pushback against that goes like this. So I think quite clearly, if you can mobilize 4 of your relatives to come as a possible donor, it's not that there's a lack of willingness to donate. But I think that's an important thing we need to think about. So perhaps just to clarify, because I don't think it came across properly in what I was saying, the reason that 3 out of the 4 potential donors can't donate is not because they're not deciding they don't want to donate. That does happen. It's not a match. It's because they're proven to have chronic kidney disease themselves and they can't donate. That's what the problem is. That's why it's the intergenerational effect of poverty. My pushback in terms of, I think what you're addressing is deceased donors. And my pushback in that regard is going to be along these lines. First of all, the way in which deceased donors are obtained is that you have to keep someone in a circulatory fashion. In other words, you have to have the heart beating so that the transplant team can be mobilized to harvest that organ. The problem is that you are more likely to obtain that kind of, or to have that kind of facility to maintain someone's heart pumping so that you can harvest organs in the private hospitals. Because the state sector is overwhelmed by the number of patients that they have to care for and simply don't have a spare ICU bed to keep somebody who is dead alive to donate. So where do most black patients have to go? The government hospitals. Right? That's why there's an issue. That's why there's this perceived lack of donation. The other really important thing in understanding why, for example, black families might choose not to donate their deceased loved ones' organs is it's quite, the problem is often getting hold of the family members to consent them to allow donation to proceed. And that's also, you can't ignore the effect that sort of like financial aspects play in that role. Sometimes you just cannot contact people because they don't own a cell phone. Sometimes they can't pay to come in to speak to the transplant coordinator. So I think we must be very careful about that kind of thing. I don't think that there's not a will. I think that perhaps there is a lack of knowledge about it because it's not, donation is something which is not widely discussed in the general media. But I don't think that it's necessarily that there's a cultural bias against donation. I think, in fact, our experience in working up donors, living donors, goes that there is, in our black patients, a very strong family ethos where people want to donate. That's why they bring 4 donors to find one.
All right, we're going to need to work towards wrapping up. So I'm going to give each one of you closing remarks in the context of the topic. The topic was about primary health care and how that can actually help to ensure access to kidney health for all. So this conversation around the cultural things, I mentioned earlier there's Dr. Naika in KZN at the event, but she's one of the nephrologists up here. And I actually mentioned this thing that, there seems to be an issue with the donation or willingness to donate by, black people and stuff. And she gave me the answer that you just gave, that actually it is not true, and then she mentioned the studies that they have done. But I must still say that sometimes people who have signed up as donors, who've told their families that, please, should I die and I'm brain dead, I would like, my body to be used to donate those things that can be donated. But quite a number of times, some families override that wish, that wish. But I can't say what percentage of people, but there's still that belief that, what are they going to do with my body, my organs? Those who think Muti, could they be using, yes, they donate the kidney. What if they take another part and use it as Muti? So, but I think education, building the trust, obviously can deal with those things. But about the living donors, I'm seeing a lot of people especially people who had end-stage kidney disease with lupus and stuff. You know, sisters coming to donate a kidney to a sister who's got that problem. So I think there is progress, but I think in terms where one picks up that there are cultural issues, I think sitting down, explaining things, explaining them in the way that their frame of reference would actually still, you know, ensure that that problem is addressed. But anyway, I'm going to give Lauren, you'll be the last one to comment. Just closing remarks. We started late, but we don't want to stretch people. It's still midweek. So please, your closing remarks in the context of the panel discussion and the topic around primary health care.
Sure, so in closing,
Oh yeah, sorry.
in closing, I think it's important to remember the leading causes of chronic kidney disease prevalent to us: hypertension, diabetes, HIV, and these are your patients you possibly want to screen. We have to work together and implement who to screen, when and how in a cost-effective manner. Early referral is most important, screening is even more important, but knowing that, as Dario actually mentioned, we have a burden of chronic kidney disease. So early referral again towards to a nephrologist, but also understanding the concept of transplantation, because dialysis is really a bridging to dialysis, and
Dialysis is a bridging to transplant.
To transplant, sorry, and to increase the pool of donors. And that really needs to be the focus. Aside from this being just primary health care, we need to realize what really is existing, as we do have disease, and secondary prevention also is important.
Thank you very much.
All right, before I close, I just want to agree with you when it comes to how the family that remains is the one that makes the final decision on donation, and add my mother to that 1%, or add my mom to that percentage, because she blatantly told me, you'll be dead, so you won't know that I'm not going to allow it, you know.
Yeah.
And that's the mindset of some of our
She was saying that to you.
To me, when I was telling her I'm signing up and this is what's going to happen, and she says, well, you won't know, because you would be quiet by then, it's not going to happen. So that's the general approach that some of our elders actually have. But in closing, I think I want to agree, firstly, with the fact that empowering our patients at primary healthcare level communities is most important. Migrating to self-screening, I think there's too much red tape around screening in our country and in our systems, and it does not work well for our patients with an overburdened health system where numbers are undeniably high. Empowering our personnel at primary healthcare level for early detection is also quite important. Moving away from hospice-centric, doctor-centric approaches, and making sure that we understand that with enough training, even our community healthcare workers can be part of this solution. Thank you.
My only issue though, if I just go back to home testing for HIV in the early 2000s, there was a big resistance to ensuring that people have got or have access to home test kits. And the issue there was about interpretation of the results. All right, so as we are seeing more and more conditions now where people have got access to self-testing, but what do you think around the interpretation, correct interpretation of what they find? You know, because with HIV sometimes things are not always clear-cut.
So those are called usability studies, and a lot of them have actually come out positive as far as HIV self-testing and HCV self-testing.
Yeah.
So it's about how less complex the test kit is in interpretation.
Thank you. Lauren, you'll be the last one. Kelly?
Yeah, so I think, you know, my takeaway from this is that as patient advocates, we play a really, really big role in guiding patients from an education perspective, what they should take into account, what they should consider, and the whole screening space. I mean, we advocate all the time in terms of newborn screening, but I think now we want to advocate for kidney screening too, because like it's something that we don't necessarily think about. And we certainly see the compound impact of identifying the kidney issues later on in the journey. And it's really, really heartbreaking where so many interventions have happened to try to keep a patient healthy, and the kidneys will land up being what is, you know, that like takes them down at the end of the day, because the treatment team has kind of forgotten about the kidneys in the process. And like, I feel like Norms and I, like, we need to think of really, really innovative ways to continuously remind patients, like, when was the last time you've had your kidneys checked? Like, are you monitoring? Like, are you, because patients in our space take a lot of their care into their own shoulders in terms of continuous monitoring, because of the fact that their conditions are lifelong. So they try move out of that primary, you try move out of that space where you're seeing the doctor all the time and you try to take responsibility for it. I don't think we do enough in terms of encouraging them to know their kidneys better. Take your kidneys on a date.
30 seconds. Just 30 seconds.
One little thing that you forgot. When we were at medical school, long time ago, there would be oral exams. After you've written and you've done your practical, then there's the oral exam. You've got 5 minutes with the professor. You must answer as many questions correctly as possible. And if they ask you a question and you don't remember at that time, the trick was to say, can I come back to that? So they can go and ask other questions. Most likely, by the time your time ends, they haven't gone back to that question that you didn't know. Trying to maximize your time. So she had time, but she forgot this one little thing, and she wants to just make that comment.
There's just so much to say. We didn't actually forget, but you actually reminded us that the simple things that your self-sustaining patients can do, aside from tight blood pressure control, would be reducing their salt intake, exercising 150 minutes per week, smoking cessation, and so forth. So those are big things that patients can do that can actually do things that equate to reduction in blood pressure, reduction in obesity, and then therefore reduction in the incidence of or the development of chronic kidney disease in a vulnerable cohort of patients or our patients.
Those are the things we're telling the guys today. Those who did come back with some challenges in the screening.
It's not just screening.
In the screening. So what can I do? I mean, quite a number of people didn't know that we're hypertensive, and so I had to sit down and think, what can I do practically? Well, there are these people who, when they get food, even before they've tasted the food, already they are putting salt. I'm actually that person. I do that. It's okay, please. You reduce the salt intake. You drink a lot of water. You exercise 150 minutes in a week, and all of those kind of things. So they are very, very important. They are practical things. All right. Have I come to you?
That's my turn.
It's your turn.
It's my turn now.
You see, that's the benefit of being the host. Because then everyone can say everything, but at the end, you have the last say.
First of all, I wanted to say thank you very much for the discussion, and I think just the discussion today has highlighted how far-reaching kidney disease is in the population that we have, but also in the various disease areas that we treat. And I think it's something that we have seen that we need to, a concerted effort by all of us to look at how we start increasing the awareness of the potential lifestyle issues as well as the treatment issues that can affect the kidney. And so we're thankful for all your comments today, and thank you. And we hope that as the months pass on and we start focusing on the kidneys in different disease areas, we remember that the kidney has a lot to deal with, and we should be looking after it all the time.
Those twins must look after them.
Yeah, the twins.
Yes. So, I talked earlier about this Phakamisa program, which has got certain elements. One of those is awareness and training. And Dr. Davis mentioned the fact that at primary care level, there may be a need to upskill the people at that level. And so, being a person who likes to connect people, I think you need to be connected with their institution, so that there can be those training programs, and people can get what we call continuous medical education points, with your association, organizing those kind of things, so that we are empowered. Because sometimes, because You know, I passed medicine in 1989. That's a long time ago. So there are things I need a refresher on, you know, and it helps to have people who are in academia, who are at the cutting edge, to just refresh us, and we get points in the process, and we deliver better care to our patients. So with those words, I don't know if there's anything else you'd like me to say, but thank you very much for all of your time. It's Thursday, and in other places it's a Puza Thursday, you know. But we've had a knowledge empowerment Thursday. So thank you very much to you all. We appreciate you. Thank you.
Yes.